Alright, so you're wearing a pretty necklace, and you take a little pill 3 times a day. But why do you actually do that? You have to do this because your adrenal glands are sick. Your adrenal glands are inside your body. Look, there they are. Usually, they make very important things for your body that give you energy. But because your adrenal glands are sick, you don't make any of those important things anymore. That's why we put those important things into a little pill, so you get all the energy you need to go out and play. But sometimes, something really exciting happens, and you get butterflies in your stomach. You know, your birthday is coming up, you're going on a holiday, or maybe you have a fever. Then your body needs a lot more energy, and you have to take extra pills. Because if you don't, you get nauseous, dizzy, and you could get very sick. And you don't want that, of course. And your necklace, you always have to wear it, so that everyone knows your adrenal glands are sick. And if something goes wrong when your mummy and daddy aren't around, other people also know that you need more of those little pills.
Hello and welcome to the Comlex Instant Review. Let's talk about another high-yield topic known as congenital adrenal hyperplasia. First, we'll start off by talking with 21-hydroxylase deficiency. The classic form usually has salt wasting, whether severe cortisol and aldosterone deficiency. In the simple virilizing form, which is not salt wasting, is the other type. So the first type has salt wasting, where you have cortisol and aldosterone deficiency, and in the second type it's a simple virilizing form without any salt wasting. There are 2 genes that you should be aware of. One is a pseudogene, but 90% of the mutations are due to recombinations between the 2 genes. The others are deletions from unequal meiotic crossovers or non-reciprocal transfers. So there can be varying effects on the enzyme activity. Keep in mind that major effects of salt losing will be from severe adrenal insufficiency in the first 2 weeks of life. So patients who come in with anorexia, vomiting, progressive weight loss, weakness, dehydration, hypotension, hypoglycemia, hyponatremia, hyperkalemia, and metabolic acidosis will all have common signs of congenital adrenal hyperplasia due to 21-hydroxylase deficiency. Let me repeat some of the high-yield symptoms you'll see. Weight loss, weakness, dehydration, hypotension, hypoglycemia, hyponatremia, hyperkalemia, and metabolic acidosis. The most important problem is going to be prenatal androgen excess. And mainly this is caused by a shunting to testosterone synthesis which occurs. What happens in males is that they appear normal, whereas females will have masculinized external genitalia. They'll have clitoromegaly, partial or complete labial fusion, urogenital sinus, which is common vaginal and urethral opening, normal ovaries and uterus. So again, they'll have a lot of signs and symptoms that vary. There's also continued postnatal shunting to testosterone. Patients have continued masculinization in females and precocious puberty in males and accelerated skeletal maturation with height and early epiphyseal closure. So the trend here is going to be females with pre-masculinization and males with precocious puberty. The initial diagnostic steps include a workup for ambiguous genitalia, defining the anatomy, looking for anatomical abnormalities, doing an ultrasound or a karyotype. All these may be options you can take. Next, the lab studies have to show a serum screening test for serum 17-OH progesterone. So the 17-OH progesterone is the best test before and after stimulation with IV ACTH. Now what you would expect to see is decreased cortisol and aldosterone in the salt wasting form, increase in renin and an increase in ACTH. And again, that's what you would expect to see when you carry out the lab test. Prenatal diagnosis in first trimester by CVS can be done if the previous child had a disease as well. For newborns, 17-OH on filter paper screen can be done. However, it has the risk of a lot of false positives. The treatment is going to be glucocorticoid daily, hydrocortisone plus, if it's salt wasting, then fludrocortisone for the minerals that the patient needs. So let's review 21-hydroxylase deficiency one more time. The patient presents to you with anorexia, vomiting, progressive weight loss, weakness, dehydration, hypotension, hypoglycemia, hyponatremia, and metabolic acidosis. On physical exam, you see signs of masculinization in females and precocious puberty in males. Screening test is going to be 17-OH progesterone. Then the best test is going to be the measure of the 17-OH progesterone before and after stimulation with IV ACTH. The treatment is usually glucocorticoids daily, hydrocortisone, plus if it's salt wasting form, then a mineralocorticoid can be added. So 3 key things: the symptoms, the lab test, which is serum OH progesterone, and the treatments, which is glucocorticoids. In the symptoms, if you had to remember 2 or 3 things, then look for dehydration along with androgen excess and weight loss with a condition where there's an aldosterone deficiency. It's very easy to look at the symptoms and just pick aldosterone deficiency based on just the electrolytes. So looking at the weight loss, anorexia, vomiting, and dehydration along with the masculinization features is a clue that this patient is suffering from congenital adrenal hyperplasia due to 21-hydroxylase deficiency. That was a board review for the COMLEX and USMLE board exam. Please visit comlexflashcards.com for additional board review lectures. That's www.comlexflashcards.com. Thank you and good luck in your preparation for the board.